I'd like to now invite Dr. Douglas Brooke. I've made him a doctor now, so Dr. Douglas Brooke to come forward and talk to you.
Actually, I'm the commencement speaker at Fordham next month, and they're giving me an honorary doctorate. So, but I, as Congresswoman Lee stated earlier, I proudly, very, very proudly, identify professionally as a social worker. So, I am. As our friend Joanne Keatley, and thank you so much for inviting me here. I feel like I don't know where we are on time for everything. All right, so I want to move, so if you can help me or someone can help me, I want to be done in ideally 10 minutes because I want to leave a chunk of time to hear. Okay. And there's so much, and you know, sometimes things change in the moment, and the way I had planned to open this is very different than when I stepped up on this stage. You know, when you live as you do around the world, around the country, around the world, and you hear news, you see things on television, it may hit you in a special way, but it's different when you internalize it, experience it locally. And what happened to me after I came up on the stage, I remember very much hearing this story about a 30-something, I think 37-year-old African-American transgender woman who was killed in Oakland. It was very, very different for me, and I remember being struck by that. It was a very different thing for me when Tiffany Woods, just a few minutes ago, reminded me that Brandy was actually killed just a couple of blocks from here. And it reminds me of a lot of things. One, the fear, you know, I don't think I ever thought I was transgender, but certainly I was absolutely a non-gender conforming young boy, a sissy, I mean, and the fear, yeah, hear it for the sissies. And what I do know is the fear and the trauma of feeling unacceptably different. And so I wanted to ask, to the extent that you are able and willing, if the folks in the room who do identify as transgender are willing to stand, I just want to see you. So, and we applaud also those who may be transgender who are in the room who chose not to stand for whatever reason. But it's important to, one of the gifts of being in the position that I am in, working on behalf of the President of the United States of America in the White House, is I get to go to places and I get to say to people, I see you. And so I want you to know that you are seen, and I want you to know that you inspire me, that you are courageous and bold and brave in ways that I don't know that I ever could imagine. And I just thank you for who you are, for what you do, for putting yourself out in the world. And I'm honored to be in the same space, breathing the same air that you breathe. I'm going to talk about updating the national HIV/AIDS strategy. I'm going to move through that quickly. And I want to, and one of the things I'm going to say is we're not doing enough around transgender issues. But it's true. But I want you to know that this clip, so first of all, you did this. You may know that in our administration, If 100,000 people, if you go onto our website, whitehouse.gov, you post a petition, and you get 100,000 people to sign the petition, we have committed to responding. In response to Leila Elkhorn's suicide, we got 120,000 signatures on a petition, and therefore we're obligated, per our commitment, to respond to that. A lot of that, I'm proud of it, I won't deny. But a lot of that work happens, at various levels, at my level, at the folks at the worker bee level. This particular issue, the last speaker, Valerie Jarrett, is the senior advisor to the president and well known, one of his most trusted confidants. And Valerie was deeply personally involved in our response to this issue. And I want you to know that I know for a fact the President of the United States of America was briefed on every piece of action that we were doing in response to this. Your president cares about you. He understands the importance of these issues, and we promise to you that we are committed to doing everything that we can over the next 19 months to make this world and make our society a better place for transgender people in the United States of America, and we hope by extension in the world. So you'll be reminded that the National HIV/AIDS Strategy has a vision that the United States will become a place where new infections are rare, and when they do occur, every person, regardless of age, gender, race, ethnicity, sexual orientation, gender identity, or socioeconomic circumstance will have unfettered access to high-quality, life-extending care free from stigma and discrimination. That's a big old vision. That's a bold step. Okay, we'll move on. We have 4 goals of the strategy: to reduce new infections, to increase access to care and optimize health outcomes, to reduce HIV-related health disparities, and to achieve greater coordination in our national response. So as we're looking at updating the strategy, we're looking to update this, our national, the document that drives the U.S. government and our partners' response to HIV domestically. I note here it's a national plan, not a federal plan, because it is those of us who are working in the government, but it also includes you and the work that we need for you to do. We're going to use this as an opportunity to merge the HIV Care Continuum Initiative and the document on the intersection of HIV, violence against women and girls, and gender-related health disparities all into the strategy. So we have one guiding document and a federal working group that's moving and advancing that work. We need to add steps and actions that are based on new or enhanced scientific evidence. Eugene just laid that out. To provide a roadmap for our administration's work over the next 19 months, but also to serve as a transitional document to the next administration. We're going to use it as an opportunity to focus our efforts and align funding on the geographic areas and the key populations where we see disproportionate burden, to set bold targets for achieving those goals, to incentivize excellent programs, and to eliminate what's not working. We need to address systems issues, categorical issues, and we're having to be practical, because the sooner we can get this done, the sooner we can get it out, the sooner the work can begin, and we can move forward. Some guiding principles: a concise plan that identifies a set of priorities and strategic actions. We're going to set clear priorities and provide leadership for public and private stakeholders. I want to say to you that I've been in touch with corporate and foundation funders. They are and will continue to be involved in this planning, because they also want to be able to align their efforts and their funding to the strategy that we develop, so that we can get some things done that we just haven't been able to get done in the federal government over years. And I'll be really clear, one of them that stands out for me is funding for syringe exchange. So, Our president has put that funding in his budget each of the years that he's been in office, and it gets over to the Hill and gets taken out. So maybe we need to turn to our private funders who are doing some of that work and get them to do more. We're going to expand approaches, ensure that prevention funding is allocated consistent with the EPI data, and focus our public investments to achieve a maximal response. We are moving on a timeline from now. We hope to release the updated strategy in July. We're getting federal input from our federal partners. We are going around. My policy advisor George is here with me. We're on day 3 of a 9-day, 5-city tour where we're listening and gathering input. We're doing that through other venues, and we will have a web portal. Once that's up, you'll be able to make your contributions as well. We're going to focus on federal and state actions, leveraging the ACA. I'm very, very clear that there are things that we're going to have to address in the ACA, and in fact, I'm bringing someone into our office very soon who is in the Office of Health Reform at HHS, and she's coming to our office with a specific directive from me to look at how we ensure integration of Ryan White, the Affordable Care Act, our prevention, our categorical grants, and insurance. So we're on it. We'll have an action plan that we'll do a release in December. So we'll have the strategy out there. The operating division, CDC, HRSA, various folks will develop with us an action plan, and we'll put that out, and that will guide our work and reporting. So the last thing I want to say is I want you to know that we commit to doing better. Because the data for transgender persons are not uniformly collected, information is lacking on transgender people in the U.S. and who are infected with HIV. But where we see the data, as Eugene just pointed out, we see the levels are high. So we in my office are committed to promoting HIV prevention for groups at highest risk, including transgender women, and if we get even down to the next level, transgender women of color. We also support efforts to collect data that identify transgender persons as such in the surveillance system. Jean talked about that, and we look forward to those data being reported when feasible. We're encouraged that reports from CDC-funded testing programs now include data for transgender persons when risk information is collected. But we also have to work with our state partners to get this done. So. In 2012, there were over 5,000 transgender individuals with HIV infection served through Ryan White. As we update the strategy, we're looking for ways to encourage collection and use of the data through surveys, studies, surveillance, and we know that the data is critical for us to accurately characterize the burden of HIV infection. I want you to know you matter. I want you to know this is not pro forma. Your leaders have our ears, and the poor data collection on transgender populations is unacceptable. That's what I know. I think that's it.